This lesson is about the cerebral vasculature and cerebral strokes. It is an artificial separation that I use because I use it clinically. As you'll see, there's going to be a cerebral vasculature that influences one of the lobes of the cerebrum, and there's going to be a different set of strokes that cause damage to brainstem and below. This separation is not anatomic, but it is clinical, because you're going to learn what each lobe does, what artery feeds it, and therefore what feature is lost when one of those blood vessels no longer perfuses that region of brain. And consciously forming good memories for clinical use later, separating it into cerebral versus brainstem is very helpful. So we're going to start off an explanation of why I do that, and then we'll lead into the vasculature itself and eventually stroke syndromes. The cerebrum, brainstem, and cerebellum are absolutely connected. There are tracks that literally run from cerebrum through the brainstem to the spinal cord and cerebellum back and forth. And so this lateral view shows us what the brain, brainstem, cerebellum interrelationship is. When it comes to strokes, there is an anterior and a posterior vasculature. The posterior vasculature consists of the vertebral arteries forming a basilar artery, giving off the anterior spinal, pica, ica, and superior cerebral artery. Part of the posterior circulation is the posterior cerebral arteries, a branch of the basilar arteries. However, the way I want you to approach this clinically is not based on anatomy, but based on what gets infarcted if one of those vessels goes down. And so while technically the anterior circulation is the combination of two internal carotid arteries forming two middle cerebral arteries and two anterior cerebral arteries, what I want you to learn is that when the PCA, MCA, or ACA are blocked, they cause ischemia in the cerebrum. Therefore, even though the posterior cerebral artery is part of the posterior circulation, I want you thinking about it in terms of the cerebral vessels that cause cerebral strokes. Posterior, middle, and anterior cerebral arteries cause strokes of the cerebrum. That's what we're going to talk about in this lesson. Whereas the brainstem vessels cause brainstem strokes, that which we'll talk about in a few lessons from now. Clinically orienting your studying of neuroscience, how you're going to employ it to help your patients, especially in the setting of strokes, forces you to do this. While anatomically, the posterior cerebral artery comes from the basilar. As we'll show you just in just a moment, the circle of Willis, the communicating arteries are itty-bitty between the MCAs and the PCAs. And so while there will be a circle of Willis and an anastomosis, clinically speaking, and how I've separated up the course, is a cerebral vasculature, ASA, MCA, PCA, which are going to cause cerebral strokes, things that happen above the tentorium cerebelli. And there's going to be brainstem strokes, things that happen below the tentorium cerebelli that are brainstem and cerebellum related. Those come from the basilar artery and have the C in them. Superior cerebellar artery, anterior inferior cerebellar artery, posterior inferior cerebellar artery, and the anterior spinal artery from the vertebral arteries. This is connected to this, but because strokes happen distal to the start of a vessel, it doesn't matter how the PCA got up there, only that it's responsible for perfusing the occipital lobe, where the vessels in the brainstem below in my model don't irrigate at all the cerebrum. They may, the structures that connect them, right, the deep nuclei and the top of brainstem, but for all intents and purposes, as we unfold stroke syndromes, you're going to see cerebral strokes, brainstem strokes. All right, what you have in front of you are two angiograms and a masterful prosection of the circle of Willis. I'm going to start first with the circle. This has been dissected away so you can see more of what's there. The whole brain has been removed, and all you're left with are blood vessels, the cavernous sinus, and remnants of the skull to show you where you are. First off, just to orient you, here's the olfactory bulb. This is the cerebral fulx. This is the optic nerve going off to the eye. Sphenoid bone. This is the optic nerve, optic chiasm. Foramen magnum. Brainstem is gone. Here are the nerves that were in the cavernous sinus, oculomotor, probably abducens. And this is the vasculature. This is the circle of Willis. You can't tell because they're all the same color, because they're all arteries. What I want you to see is that the basilar artery comes up in front of the brainstem, if it were here, through the foramen magnum, where it gives off branches that perfuse the cerebellum. But as it's related to us now, this basilar artery splits into a posterior cerebral artery on the left and a posterior cerebral artery on the right. This is the anatomic posterior circulation. This is an internal carotid on the right, giving rise to an anterior cerebral artery and a middle cerebral artery. On the left, this is an internal carotid artery, giving rise to an anterior cerebral artery and a middle cerebral artery and all of its branches. I want you to see that that is effectively three independent circulations. A left ICA, right ICA, and one basilar posterior. The reason why I'm saying it like that is because there are three communicating arteries. The left internal carotid artery system and the right internal carotid artery system link together through one anterior communicating artery between the two anterior cerebral arteries. And then you'll notice that the one posterior basilar dependent posterior cerebral artery circulation each receives one connection. The left internal carotid artery sends off a posterior communicating, which then links up with the posterior circulation. The right internal carotid artery circulation does the same thing, a posterior communicating artery to the posterior circulation. This is the circle of Willis. They are major vascular territories. You can tell by the size, by the width of these arteries, that the main distribution of these, the left internal carotid artery is going to be perfusing the middle brain and the anterior brain on the left side. There is an anastomosis, but look how small it is relative to how large the middle cerebral artery is. The same thing is true on the right internal carotid artery. Obviously, this thing is going to be perfusing the anterior and middle cerebrum. There is a connection, but it's not that big. Same thing with the PCOM on the right. All right, so starting there, that's the circle. That's all the major arteries that are named. Then I want to know where they come from. All right, so we're going to switch over to an angiogram. This is a top-down angiogram, basically showing us what I just showed you. Vertebral arteries form a basilar artery, gives off posterior cerebral arteries. This is an internal carotid coming up into the cavernous sinus and back out, where it gives rise to a middle cerebral artery and an anterior. The middle cerebral artery has a wide distribution, lots of branches. The left internal carotid comes up and gives rise to the left anterior cerebral and the left middle cerebral. It's really hard to see the ACOM, and I'm not sure which one of these are the PCOMs, but they're there. But certainly, just to prove the point, the left internal carotid is clearly on the left middle side and the left anterior side. it's difficult to see the branches of the posterior and to know which ones of these are the middle cerebral or the posterior cerebral, because they're not connected. But certainly you can get the idea that the MCAs actually go anterior and out to the side, where the posteriors are coming directly posterior. Lastly, we've got a little bit bigger one. This is one that was done from the back to the front. Right, so you can see here, there is a vertebral arteries forming a basilar artery. This is probably the superior cerebellar artery because the bifurcation is right there. That's the posterior cerebral. These big guys are the internal carotids. And that you can tell that when they start to jig like that, that they've just entered the skull, and here they are coming out the cavernous sinus. These internal carotids are going to give rise to the middle cerebral and in all of its branches, and the anterior cerebral and all of its branches. Here you can see the ACOM. And this side, same thing. Here's the middle cerebral and the bifurcation to make the anterior cerebral. Again, the posterior communicating arteries they're there, but I can't see them and I can't show you the connections between them, so I don't want to point them out, and I don't know exactly what they are, but it looks like this one is one. So, 3 circulations, 2 anterior, 1 posterior, connected to each other by communicating arteries. The most important thing to take away from that is that there is a posterior circulation, basilar, which includes the posterior cerebral arteries. We know this because these tiny little PCOMs are going to connect each of the PCAs to the MCAs. But based on what we talked about metaphorically, cerebral vasculature involves the PCAs. And so instead, what I want you to see, because of the PCOM business, there's actually 3 sources of blood. There is a right internal carotid artery, a left internal carotid artery, and a basilar artery. The reason for that is while there are communicating vessels, and these communicating vessels have significant anatomical variability person to person, I want you to see that the right ICA has a large caliber lumen associated with the right MCA and the right ACA, and a little PCOM connecting to the other ones. The left internal carotid artery has a large lumen between the MCA and the ACA, and a little connection to the other ones. The basilar artery has equal connection to the PCA. In this sense, you can see a left-right mirror, and even though there is an anastomosis, you can certainly feel that a skinny PCOM is not going to be able to conduct as much blood as a large PCA. And so what I don't want you to be doing is thinking anterior and posterior. Definitely not. Because while that is true, basilar artery, here it is, I just drew it in blue, right? This is the posterior circulation. In terms of the cerebrum, it doesn't work like that. And there are 6 vascular territories. Because as soon as you leave the circle of Willis, any obstruction distal to the circle is going to lose all of the blood supply of that territory. So now you actually have 6 territories. The left ACA, the left MCA, the left PCA, the right PCA, the right MCA, and the right ACA. There is no collateral circulation between these, and if anything, there's watershed areas. The cerebral fault separates the anterior cerebral arteries from each other, and so they cannot be responsible for perfusing the other side, which means that you're going to be able to lateralize any symptoms if someone has a stroke, and you're going to know what vascular territory each of these perfuses and know what happens in that thing. When there is a stroke, they will lose the ability to do whatever it was that artery perfused. That's what we're going to get into next, starting with the anterior cerebral artery. This is a figure on the anterior cerebral artery. The anterior cerebral artery will be represented in green in this lesson. And so, to orient you, we first have the mid-sagittal section. You can already see that the vascular territory has been labeled. We've taken our partner's sample and applied a Photoshop to it, right? So we've actually colored in the thing green. It wasn't green. To orient you, here is midbrain, pons, cerebellum, medulla, brainstem. This is the corpus callosum. And here you can see the cerebral falx has been dissected away. This is the frontal lobe and a bit into the parietal lobe, cingulate gyrus. So you can follow the anterior cerebral artery where it branches here. You don't see the rest of it, but this is the circle of Willis. It goes into the median plane and essentially wraps around the corpus callosum. Now, its name is going to change if you look in vascular textbooks, but really that's what it is. And you can see it sends branches out and up and over and into the sulci. So the main artery is laying right against the corpus callosum, tossing arteries over the top and into sulci and gyri. Frontal lobe, median portion, and parietal lobe, medial portion. You will also note that on this figure, the green has been applied to the very top of the lateral portion. As we saw in motor systems and sensory systems, this was the case, and we restricted it to the given pre- and post-central gyri. Now you can see that the ACA is responsible for that same strip of tissue the whole way around. And here you can again see that the anterior cerebral arteries are sort of just laying on top of the corpus callosum. Now the falx cerebri has been removed, of course, otherwise there would be a structure in between them. But you can see how the artery sits on the corpus callosum and then throws the arteries up. And here you can see from a different perspective of the circle of Willis, there's cerebral aqueduct. This is midbrain. And here you can see the internal carotid rising, give rise to a resected middle cerebral artery and an anterior cerebral artery. The ACOM isn't visible because it's between the two of them, but that anterior cerebral artery is going to go into another internal carotid where it will give rise to a middle cerebral, which isn't present. There's a PCOM. And so as the segments go out, they get named certain letters. I don't want you worried about A1, A2, blah, 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 just that it's A, green, forward. This is the optic nerve. Right underneath this is the optic chiasm. So you can see how the anterior cerebral artery sort of uses the corpus callosum as a guide, right? Keeps it focused while it reaches its branches up on the median side of the frontal and beginning of the parietal lobe, as well as reaching over on top of the frontal lobe and parietal lobe on the lateral side. Specifically what this means and why this matters the most is because it's going to irrigate the somatosensory cortex and motor cortex that controls the legs and feet. A stroke of the anterior cerebral artery will present with upper motor neuron lesions and a loss of sensation, both pain temp and vibration sense, of the lower extremity on the contralateral side. Now let's talk about the MCA. Now, just as we did for the anterior cerebral artery, we're going to do for the middle cerebral artery. Start off with its vascular territory. This is the left lateral view with the temporal lobe resected so we can see inside the sylvian fissure. And just as the anterior cerebral artery sort of laid on top of the corpus callosum and projected branches in all different directions, so too will the middle cerebral artery. It does a bit more than that, but in the same sense, it's going to emerge from the circle of Willis just out of sight and wrap around onto this side, run up the sylvian fissure, and project branches in all different directions into the sulci and over the surface, just like the anterior cerebral artery did. It comes out of the internal carotid artery, which bifurcates to make the anterior arteries over the chiasm, and then the middle cerebral artery. It traverses laterally at first, and then immediately is going to take a turn around the sylvian fissure, around the insular, and in the sylvian fissure. These are all the different branches. I don't want you to pay attention to that at all, but I do want you to see that the internal carotid artery becomes the middle cerebral, and it takes a turn around the insula. And here it is taking that turn, coming out into the sylvian fissure. Now we've again colorized to make it easier for you to follow. This is the main segment, and it immediately takes 3 branches. And the branches have branches, and the branches have branches, have branches, have branches, have branches. Again, M1 through M4, I just want you to know that it's middle cerebral. It travels within the sylvian fissure. It projects branches in all different directions. It takes care of the medial temporal lobe, the lateral frontal lobe, and a bit of the anterior lateral parietal lobe. The space not colored in would be handled by the anterior cerebral artery, and everything behind it would be the posterior cerebral artery, which we'll talk about next. All right, so the MCA has a pretty large territory, and it's also a territory that has a lot of impact on people's consciousness and perception. That is a large part of their motor and sensation for the parts that matter a lot, hands, mouth, muscles of chewing and eating, as well as expressing speech, can be compromised by an MCA stroke. And the MCA is also responsible for irrigating those deep brain structures like through the lenticulostriate arteries. The problem is that you usually do not have an MCA stroke because the MCA is so large, but you can have one of its branches. And so a couple of things can be taken down, and these are things you should be aware of. Of course, there's way more than this because you can see how much vascular territory it has. But I want you to see that Wernicke's aphasia, Broca's aphasia, and the problems of somatosensory cortex and primary motor cortex of the hands, face, and mouth can be affected. Which means that if you have a Wernicke's aphasia, you're going to have a receptive or a fluent aphasia. Wernicke's is the thing that lets you speak comprehensively. Broca's lets you actually make the words. So if you have a Wernicke's aphasia, you'll be fluent, but not make any sense. And Broca's, you'll have an expressive aphasia. You'll know what you want to say, but are unable to do it. And hands, face, mouth can have problems with swallowing, speech, and fine motion. Let's talk about the PCA. The posterior cerebral artery territory is actually the most difficult to demonstrate. It's everything not ACA and MCA, which is why I showed you those two first. And after seeing the MCA territory, you could sort of see how much the posterior cerebral artery is going to perfuse, right? It's definitely the occipital lobe, the bottom of the parietal lobe, and anything underneath the temporal lobe that the middle cerebral artery missed. And so there's also the bottom underside of the brain, which is what we've tried to depict here, right? This is midbrain, substantia nigra, crus cerebri, right? Cerebral aqueduct. The posterior cerebral artery, barely visible for very long because it gets lost in the sulci. Here it is here, and here it is here. It's covered by purple. We're trying to show is that it's going to manage a lot of the underside of the temporal lobe and then curve around back to take care of the occipital lobe. This is the front of the temporal lobe, or the olfactory tracts. This is frontal lobe. The posterior cerebral artery obviously does not get anything frontal, but it's going to get everything temporal and everything occipital and anything else that the MCA and the ACA don't get. This is a depiction of the posterior circulation. I don't want to get into the details here because this is not the lesson. I want you to learn this stuff, but to show you some things that have been familiar in the conversation so far, the two vertebral arteries meet to form the basilar artery, and the basilar artery splits into two posterior cerebral arteries. This is a multiplaned section. This is superficial, this is deep, right? So there's the substantia nigra, crus cerebri, red nucleus, superior colliculus, inferior colliculus. And what this is trying to show is way more than we need it to, but we've chosen this one to depict. The basilar artery can barely be seen, gives rise to a posterior communicating artery. The PCOM is located here, and in this person it was more robust than we saw in the first. But regardless, what we're trying to show you is that rather than going to the front of the brain or the left of the brain, the posterior cerebral artery comes to the back of the brain. All right, so the posterior cerebral artery, that pretty much takes care of everything else. And for the most part, it is going to be the occipital lobe and the underside of the temporal lobe, which means that because the occipital lobe does a lot to do with processing vision, most of the PCA stroke symptoms are going to include visual cortex. We're not going to go through this in detail now. We will.